Bienvenidos, benvindos. Welcome to the Latin American Forum on Stigma and Discrimination 2020. Today we will be working on understanding the implication of stigma and discrimination on HIV/AIDS. Mark Nelson is the program chair of these forums. Mark Nelson is a consultant physician at the Chelsea and Westminster Hospital in London and a professor of HIV medicine at the Imperial College of Medical School, where he's also the senior tutor. He has been awarded a visiting professorship in the Aga Khan Hospital in Nairobi, Kenya, and most recently the Certificate of Merit by the government of Vietnam. In the case of this edition of the Latin American, I will be chairing together with Mark today. My name is Javier Bellocq, and I am the editor of the LACI correspondent team. I'm also working since the last 32 years on HIV/AIDS and also specializing on understanding auto-stigma, stigma, and discrimination. So we hope that today we will come together in a very interesting and interactive forum. For the opening session, we have two key speakers. The first one is Dr. Mauro Schechter from Brazil. He will be speaking about stigma and discrimination in 1990. And the second speaker will be Bruce Richmond, who is a member of the Prevention Access Campaign from the US and the champion of U=U. So let's move to the first session of this forum that will be reflecting on what does U=U mean for community in the real life. So we have a very important panel of community leaders. Let's start by Alicia Kruger, who comes from Brazil, Giseli Flores from Peru, Veronica Russo from Argentina, Simon Casal from Paraguay, and I will give you more details from the speakers when I presented them. So now we're moving into session 2, the role of prophylaxis pre-exposition in reducing stigma and discrimination. We have, again, a very interesting panel composed by Bruce Agnins, Alice Kruger, Alessandra Ramos, and my colleague Mark Nelson will be facilitating this session. Today's forum has been possible thanks to the support of the educational partner. In this case was Erasmus Medical Center. We also have multiple organizations that endorse this event who are critical to the response to HIV, stigma, and discrimination. You can see the names in the screen. The Latin American Stigma and Discrimination Forum 2020 has been supported by an independent educational grant from PLWHIV Healthcare. PLWHIV Healthcare was not involved in the development of the content or selection of the faculty for this educational activity, and we are very grateful for the support of PLWHIV. Your feedback is very important. After the forum, a survey will be sent to your email. Please complete this short survey and you will receive a certificate of attendance. Your feedback is valuable and helps the program chair to further improve the forums. So let me introduce the first speaker, Professor Mauro Schechter. He will be presenting how stigma is impacting the 1990 goals. Mauro Schechter is currently a professor on infectious diseases at the Department of Preventive Medicine of the Federal University of Rio de Janeiro, Brazil. He's also adjunct professor of epidemiology at the Graduate School of Public Health in the University of Pittsburgh, and an associate in the Department of International Health in the Bloomberg School of Hygiene and Public Health in the Johns Hopkins University.
Good afternoon, everyone. Initially, I'd like to thank the organizers, particularly Mark, for inviting me, and Javier, of course, inviting me to give this presentation on how will stigma impact the 1990 goals. As I believe most of you know, in 2014, the UNAIDS, the Joint Program on the United Nations on HIV/AIDS, they launched this initiative called 1990, which according to them would be a new HIV treatment narrative that will lay the groundwork to end the AIDS epidemic. If we look more carefully, they said that would be the final chapter of the AIDS epidemic. But what is 1990? It is that 90% of the persons living with HIV/AIDS are diagnosed, 90% of the diagnosed ones, are linked to care and started on ART, and 90% of persons on ART would have an undetectable viral load. But the question is could it be the final chapter of the AIDS epidemic? What does it really mean? A strategy to end the epidemic, or a metric to evaluate and compare HIV/AIDS programs, see how they're doing? And when it was launched in 2014, and I've said that many times for people who know me, it already did not make sense to my mind, because we knew at that time, if 1990 was reached, the epidemic would not end. These are data from the UK showing in 2013 that 1990 had been reached a long time before among MSM in the UK. And as you can see in the top line, the top blue line, 1990 had been reached many years ago, and the number of cases kept going up and up and up. It had gone up 25% in the previous decade, in spite of 1990 hadn't been reached. So why could it not be the final chapter? First, because a fourth 19 is missing. It's not only getting to be undetectable, you have to remain undetectable for 90 years, for the whole life. And more important to me, it medicalizes the response, leaving the responsibility entirely on the hands of the governments, physicians, pharmaceutical industries. It did not include societal involvement. And I think a gross mistake, knowing what we know, that it presupposed that we can treat ourselves of the epidemic. And they have the example of syphilis. Syphilis has a very short transmission period as opposed to HIV. It's 100% curable as opposed to HIV with 1 to 3 shots. Under DOT, directly observed therapy, is extremely cheap treatment. Everything the opposite of HIV. And we have not eliminated syphilis, have not reached the final chapter of syphilis. Exactly the opposite. So, to our theme, the first 90 is diagnosis. And data from Argentina, if you look at one of the populations that most affected by stigma, transgender women, for you to be diagnosed, you have to come into contact the health system. And 41% of women, trans women, they say they avoid contact with health services. Why? Because of discrimination by healthcare workers and by other patients. So there you are, you cannot even get diagnosed if you don't have contact with the health system. And the other 3/4 to my mind, they're all the same things: treatment, adherence, persistence, starting treatment, stay on treatment, adhering to treatment, persisting on treatment. They're more or less the same. And if we look at data from all over the world, these are aggregate data from 41 countries in all the continents. It's known that by the 3rd year after starting treatment, at least around 50% of patients are not more in care, are not retained in care. It's not that they are not undetectable, they're no longer in care around the world. Doesn't really matter how you slice the pie, if by gender, by clinical stage, by the age they started ART, or their CD4 count. And even if you look at countries, people who stay in care, like the UK, when we don't have shortage of drugs, the drugs are there, and we hear people stay in care. And this here, it shows people who are in care and how many experience virologic failures after being in care for many years. And if you look on the left, bottom line is the time on ART. And if you look on the bottom left, of people who have been in care 6 to 8, 8 to 10, or 10 to 13 years, still being in care and undetectable, say after 6 years, undetectable, 6% fail. And we're talking being in care and persisting undetectable for life. And what are the predictors of all these things, of non-adherence, non-staying treatment, non-persisting on treatment? They're consistent in all of them. All studies we do, they all, in a way, or most of them, related to stigma. Lack of social or family support, or perception of insufficient support by society or family. Lack of acceptance of HIV infection. a lack of place where to keep medicines, which is a indirect measure or a demonstration of stigma, depression, and suicidal ideation. In a way, low level of schooling at younger age, which make you a person more vulnerable to schooling, to stigma and discrimination, give the person fewer tools to combat stigma and discrimination. But when you talk about stigma and discrimination, most people, including myself, we tend to think of the so-called key populations. But here are data from the Netherlands looking at HIV-infected young adults on ART, on treatment, who fail therapy. And if you look at them, one of the largest predictors of failure is acquiring HIV by the heterosexual route. So there's something there that in another group, whom is not considered a key population in general, who in general is not seen as suffering stigma and discrimination, because we, including myself, tend to think of stigma and discrimination affecting other populations, might be also the victim of that for other reasons that we normally don't consider. And if you think of the whole of Europe, and here are data, recent data from Europe, from the European CDC. And if we look, two countries, Belgium and Luxembourg, which I marked with these red arrows, in these two countries, over 50% of new cases are due to heterosexual transmission, both among males and females. So heterosexual transmission is playing a large role in these countries. And young people, like we saw in Holland, are failing therapy. So for them, we have to also look what's happening to them and what role discrimination and stigma might be playing for them as well, not only for the so-called key populations. As I said, I think one of the most big problems is that it does not include societal involvement. Because stigma is not an individual attitude. Stigma is a societal attitude. It is a discrimination against a group, people, disease, a place, a nation. It is associated with lack of knowledge about how an infection spreads, a need to blame someone, fears about a disease and death, and gossip that spreads rumors and myths. And for those of us who live in Latin America, we know the power of gossips, rumors, and myths, particularly now in my country, when these come from government or people closely associated to government. So coming back to my question, do I think that 1990 is the final chapter of the epidemic? Is it a strategy to end the epidemic? No. A resounding no. I don't think we can end the epidemic by treatment. But I think that is an extremely useful metric to evaluate and compare HIV/AIDS program. We need metrics to know how we're doing and how to do better. I think this is extremely important. And I conclude by saying that stigma and discrimination are the main impediments for achieving each of the 90, or the four, I repeat four, because you need to be undetectable for 90 years, or I'm joking, but for very long, goals. The 1990 goals can only be achieved through societal engagement. Societal engagement, in turn, is the only possible way to combat stigma and discrimination. And if stigma and discrimination are not actively combated, 1990 goals cannot be achieved. And I think it's also important to recap, to say that the message, to my mind, the message of the 1990 being the final chapter epidemic is the wrong message. It's the wrong message to donors, because it conveys the idea that no more funds are necessary because the epidemic is ending anyway. It conveys the wrong message to attract young investigators because, oh, well, all scientific problems have been solved. Let's investigate something else. It also the wrong message to promote behavioral changes. Because it says, well, the epidemic is ending anyway. Why should I change my behavior? But I don't want to end on a pessimistic note. On the contrary, on a very optimistic note. If you remember, right at the beginning, I showed data from the UK showing that in spite of reaching 1990, the number of new cases in MSM kept growing, going up in the UK till 2014. But then came PrEP. And when PrEP arrived, look what happened. The number of new cases dropped precipitously. It never had dropped before. The mere arrival of PrEP led to a decline in 4 years of 35% of new cases, even before PrEP is really, really widespread used. And that's been seen, for instance, in New South Wales, in Australia, and other places. For instance, in São Paulo, Brazil, although there is no real large-scale distribution among white MSM in São Paulo who have money to buy it, the number of new cases for the first time went down. It didn't go down amongst mixed race and black MSM because they're poorer and they cannot afford to buy it. And there's very little, or there's not enough in the public sector. So with them, the number of new cases kept going up. But amongst white MSM, it went down, showing that PrEP can really impact the epidemic. Finally, I'd like to thank Lucy Vasconcelos and Marcia Rashid, who helped me with the slides, provided slides and helpful discussions. And again, thank the organizers and Mark and Javier for inviting me.
Thank you, Professor Schechter, for your amazing talk. I will introduce the next speaker, Mr. Bruce Richman. Bruce is a founding executive director of the Prevention Access Campaign, which launched the Undetectable, Equal, and Transmissible campaign, known also as U=U, a global community-driven movement with over 990 official partners and 100 countries sharing a revolutionary but largely unknown fact that people living with HIV on treatment with an undetectable viral load cannot transmit HIV to sexual partners. Bruce?
Hi, thank you so much for having me here today to talk about U=U. And during this presentation, I'm going to talk about why U=U is so important and also about how did the community work together to ensure that this groundbreaking science got out to the people that it was intended to benefit. But first, I just want to mention I am an extremely privileged white cisgender male who has stable health insurance and housing and all kinds of support that enable me to get to and stay undetectable. And so many people in many parts of the world do not have the kinds of treatment, care, and support that they need and deserve to get to undetectable. We need to make sure that everyone has that option. So what is U=U? It means that a person who's living with HIV who is on treatment and has an undetectable viral load, which means under 200 copies per milliliter for the purposes of untransmittability, that person cannot transmit HIV through sex. So we stay healthy and we don't have to worry about passing on HIV to anyone. So why is this a game changer? Well, when you think about it, so many people living with HIV, like myself since 2003, never imagined a time when we could love, we could have sex, we could conceive children without fear. Fear had been present in the most intimate moments of our lives. U=U sets us free. It changes our social lives, our sexual lives, our reproductive lives, and it dismantles the stigma that we've been living with and dying from for decades. So it changes the way that we see ourselves, the way others see us, the way we're treated in clinical settings, and the way policy decisions are made about us: housing, healthcare, criminalization, education. And finally, I learned this when I entered the field. I didn't really know what the treatment cascade was or 90-90-90, but But U equals U is really important for treatment goals because it reduces the anxiety associated with testing. So more people are likely to get tested. And then if diagnosed, to start treatment and stay on treatment and stay in care for our health and to prevent transmitting HIV to our partners. And finally, this is really important. I'm going to spend some time on this, is the public health argument. And let's just move to the next slide. So what is the public health strategy? So I think we're all aligned with the goal of universal access, which is the third U, because we want to ensure that we increase access and remove barriers to treatment and care and diagnostics. And the argument used to just be, this is for the well-being of people living with HIV, and that should be enough. That should be enough of a reason to make the adjustments in budgets and allocation services. But that may not be enough for some policymakers. They may not be interested in the well-being with HIV. But now we can say, look, if you invest in the well-being of people living with HIV, you get us the treatment and the care that we need, we not only stay healthy, but that stops new transmissions. And that will get us closer to ending the epidemic. So we really need to link ending the epidemic to investing in people living with HIV. If you invest in the well-being with people living with HIV, we stay healthy, we stop new transmissions, and that gets us closer to ending the epidemic. Also, with treatment goals, there was actually some new data that came out that showed that when people living with HIV were informed by their healthcare providers about U equals U, they reported greater treatment satisfaction, optimal adherence, and viral suppression. So it's really important. We've had data now to show that it is aligned. So why did we need this campaign? Well, so we know that, U equals U, but mostly I think everyone watching this, but in the beginning, not a lot of people were being told about U equals U, and they still aren't being told about U equals U. And it's especially communities that are already marginalized by healthcare systems and facing all kinds of stigma, racism, transphobia, homophobia. They're not being shared. This information is not being shared with them. We feel that all people have a right to this information, regardless of where you live, where your background is, and what your circumstances. All people living with HIV have this right to information about our bodies. And we know stigma is a public health emergency. Right now, millions of people living with HIV around the world are suffering. They're suffering from social rejection, isolation, depression, suicide, intimate partner violence, prosecution, and murder, because they and other people believe they're infectious and they're not. We also know stigma is one of the greatest challenges to ending the epidemic, and U equals U is an immediate and effective response to ending HIV stigma. There are other intersectional stigmas, but when we're talking about HIV stigma, U equals U goes a long way. So what do? We talked to the scientists and we worked on a consensus statement to confirm that U equals U was true, because there were so many mixed messages back then. So from January 2016, we worked on this together. The scientists from the major studies were wonderful partners with us. We created a video with the voices of people living with HIV, demanding this information about all of us. And our strategy was to take that statement and the video and our voices and go out and change the narrative about our bodies by engaging influential people and institutions and confirming and joining with us to support what we knew was true. We launched in July 2016, and we were very happy that right around that time, New York City Department of Health signed on as the first city in the world to declare U equals U, and in England, Terence Higgins Trust was launching their campaign and has now become a global leader in U equals U. Also at that time, we started talking to the CDC and NIH and US health departments that we knew would have an influence worldwide if they changed their risk assessment. And fortunately, the relationship at times was heated, sometimes it was difficult, but we really worked together well and came to a place where the CDC and federal health departments updated the risk eventually, I think as most people know. But what happened at that time, the reason that we got here was because of the activists. It was because of this community, this groundswell of people all around the world on every continent that stood up and said, we demand the truth about our bodies. And they were pushing their health ministries, they were protesting, they were marching, they were creating music videos and songs and dancing in the streets to say, we need this information about our bodies. We demand the truth. We did have friends at high places. So Dr. Anthony Fauci, arguably one of the leading immunologists in the world, said the science does verify and validate U equals U in 2017 in public. In partnership with us, Dr. Fauci has been tremendous. He also said the risk is zero because folks were worried about saying zero risk. He kept saying there's no zero risk in science. Dr. Fauci said the risk is zero. People, you've got to say zero. We have to be clear in our communications. So that was tremendous for us. He also said U equals U is the foundation of ending the epidemic. Again, this goes back to that public health argument. Look, if we want to end the epidemic, we need things like PrEP. We certainly need other kinds of condoms and testing, but we need to tell people U equals U. There's a whole cascade of things that happen when you share knowledge about U equals U. And folks start to go on treatment and stay in care. That's the route to ending the epidemic. And now we have U equals U is verified and multilateral organizations all over the world. WHO back in 2018 made a statement. CDC Global, PEPFAR created this really great toolkits and also countrywide programs. They've invested in countrywide programs in Vietnam and Zambia and Nigeria. Really great, really well thought out programs. And also UNAIDS has been really wonderful supporter, excellent toolkit. So now we have 1,007 community partners growing every day, 102 countries. That's almost half the countries in the world. And it's in all kinds of languages. It's like 35 different languages. It's B equals B in Turkish, K equals K in Vietnam, H equals H in Russia, N equals N in the Netherlands, I equals I in Italian and Portuguese. But I'm going to show you just some important kind of milestones here. You know, we launched in 2016 in the summer, and we were looking for really important, you know, endorsements and sign-ons. And ICASO and INA in January 20th, 2017, so very early, only about 6 months after we launched, issued a statement, which was then really, you know, heard around the world, and especially in Latin America. So that was really the first endorsement of U equals U and public statement that we saw that was reaching all of Latin America and around the world. And then this video on the right here, I'd like to show you. This was really exciting because this came out in 2016, so not long after, just a few months after we launched. And it's such a clear video, the I equals I video. But what was really genius about it is that Cass and Onicida was using it to encourage testing, so to reduce anxiety associated with testing. This was the first time we saw that. Now we're seeing folks doing that around the world, and there's some data that's coming out that shows U equals U does influence people's willingness to get tested. But CAS and Onicida did this early on. Very early on, which was a big first. And then on the left here, I love this campaign. It was really a body positive campaign from Gay Latino, which was, circulated throughout their extensive networks, a bunch of different images, some groups on the left, some groups from, young people with HIV from Argentina, the positive groups from Brazil and Venezuela joined early. And then on the bottom right here is this was a major milestone in the campaign when Brazilian government endorsed I equals I and integrated into the treatment guidelines. This was in May of 2019. The U.S. Didn't do this until December of 2019, and most countries hadn't done this yet. So this was really forward for Brazil, and I really can commend you. Also, the other thing is this video on the left was for the oldest indigenous tribe in Venezuela. So when you think about how is U equals U reaching people and is it impacting all of us, this is a country, as you all know, that's facing one of the greatest humanitarian crises of our time, and U equals U and M equals M, I equals I is reaching people, reducing stigma, and really helping people there. The same with China. The program in China is run by young people, young activists and advocates, along with UNAIDS. We just did a conference in China, and then on the far right is the first video or campaign really in the Middle East. Whoops, sorry. And that one is called the Superhero Campaign. Now, I'd actually just like to play some fun things before we end. This is a song from Japan. You,
undetectable, undetectable, untransmittable 6ヶ月以上ならリスクはないよ You equals you With you equals you we can we
And this is from Zambia. This is a rock star in Zambia. So actually the one on the right that just played from Zambia was funded by the government in Zambia, the CDC and PEPFAR. This is a nationwide and all 10 provinces of Zambia, U equals U program, or S equals X, S equals S, sorry. So in closing, I just want to introduce my friend Allison Roger, who was a lead author of the partner studies, partner 1 and 2. This is what she said at the end of her presentation in World AIDS Conference 2018. And I have a cameo here.
There are many providers that are still not accepting this message. They try to focus on the risk is not zero scientifically, or they focus on their patients aren't going to be adherent and they won't know that they're detectable, or they say there's a rise of STIs already, so they don't want to share this with their patients. We get every single kind of excuse. What would you say to clinicians or any other information provider who is withholding this information from people with HIV?
Yeah, and I just want to pay tribute to the U equals U campaign. It's been astonishing. I think the time for excuses are over. I think it's very, very clear that the risk is zero. So I very much think we have to promote this. I think if you're on suppressive ART, you're sexually non-infectious, and yeah, the time for excuses is over.
Well, thank you so much. And here's some ways to get involved. And I hope that everyone who's watching this will have the opportunity to share this message with someone living with HIV, especially for the first time. It's so powerful to see how this brings hope and changes lives. The first is to join the campaign, and you can join on our website where it says community. And learn the facts. There's lots of information, research on everything related to U equals U, and share the great news in a way that reaches the communities you serve. I mean, organizations around the world are reaching every key affected population based across all kinds of identities that so often divide us. This is a chance for you to communicate this to the people that you know and that you serve in ways that will reach and touch them. And finally, we have to remember not to leave anyone behind. We need to use U equals U as a public health argument to ensure that all people living with HIV have the access to the information of U equals U, but also to the treatment and the care that they need to be able to experience it. Thank you so much.